Imagine this: a 40-year-old male presents to the hospital with progressive breathlessness over months. He also describes episodes of chest discomfort that worsen on deep breathing. Today, he feels so breathless he can barely walk a few steps. How do you approach this case? Let's explore dyspnea and chest pain, starting from their fundamentals and clinical relevance. What is dyspnea? Dyspnea is not just shortness of breath. It's the awareness that breathing is taking more effort than usual. It's like when you sprint upstairs and feel the burning need to take in more air, but here, it happens without obvious exertion. Mechanisms behind dyspnea. Increased work of breathing. Think of a balloon that's hard to inflate. When the lungs or airways become less compliant, your breathing muscles have to work harder. Thickened pleura, like adding a tight outer covering to the lung. Pleural effusion or pneumothorax, extra fluid or air outside the lung restricts its expansion. Airway resistance, common in asthma or COPD, makes each breath a struggle. Increased demand for oxygen. The body might need more oxygen than usual in conditions like hypoxia, low oxygen levels due to high altitude or lung diseases. Anemia, even if your lungs are fine, fewer red blood cells mean oxygen isn't delivered effectively. Acidosis, think diabetic ketoacidosis, where excess acid stimulates the respiratory center to breathe faster. Thyrotoxicosis, the metabolism runs in overdrive, demanding more oxygen. Impaired respiratory effort. When the brain tells the muscles to work, but they fail. Paralysis of respiratory muscles, seen in conditions like Guillain-Barré Syndrome. Breath holding, voluntary or due to reflex inhibition. As clinicians, it's essential to assess how dyspnea impacts daily life. Grading systems help. Let's look at two widely used methods. Medical Research Council, MRC, scale. This system focuses on functional impairment. Grade I, breathlessness with intense physical activity, like running uphill. Grade II, struggling to keep up with peers of the same age on flat ground. Grade III, you can't walk at your normal pace and need breaks frequently. Grade IV, even basic activities, like walking indoors, cause discomfort. Sherwood-Jones classification. Designed for bedbound or severely limited patients. Grade I, they can still do chores, though with varying difficulty. Grade II, confined to bed or chair but can rise with effort. Grade III, totally dependent. Grade IV, moribund, nearing the end stage. These grades help quantify the severity and guide management plans. Breathing involves intricate feedback systems. When something goes wrong, specific receptors signal distress. J receptors in the lungs respond to congestion, like in heart failure or pulmonary edema, triggering rapid, shallow breathing. Stretch receptors sense lung expansion and regulate effort. Chemoreceptors in the carotid and aortic bodies detect low oxygen, high carbon dioxide, acidic pH. Respiratory muscle receptors send SOS signals when overworked, adding to the sensation of breathlessness. The duration of symptoms offers clues about the cause. Minutes, sudden events like pneumothorax, massive embolism, or laryngeal edema. Hours, acute asthma or heart failure. Days, recurrent embolism, ARDS, or pneumonia. Weeks to months, pleural effusion, chronic anemia, or muscle weakness. Years, COPD, pulmonary fibrosis, or chronic neuromuscular disorders. This framework allows for targeted investigations, from bedside tests like oxygen saturation to advanced imaging. Chest pain often accompanies dyspnea, and its nature is critical for diagnosis. Types of pain. Pleural pain. Stabbing, sharp pain worsened by inspiration or coughing. Seen in pleurisy or pneumothorax. Upper retrosternal pain. A brief, burning sensation in acute tracheitis, often subsiding once the cough becomes productive. Mid or lower retrosternal pain. Constrictive pain caused by mediastinitis or tumors. Reflux esophagitis. Achalasia cardia. Pancoast Syndrome, a classic triad seen in apical lung tumors. Shoulder and arm pain, nerve root compression. Horner's syndrome, sympathetic chain compression. Rib or vertebral erosion causing constant discomfort. Pulmonary embolism, sudden dyspnea with pleuritic chest pain is a red flag. Returning to our patient, progressive dyspnea over months with pleuritic chest pain points to pleural effusion or a chronic lung condition. This emphasizes the importance of systematically analyzing dyspnea and chest pain to arrive at the correct diagnosis. Dyspnea and chest pain are common yet complex symptoms, but with a structured approach, you can transform uncertainty into clarity. Don't forget to check out Cephaly for additional resources.